Good afternoon and welcome to Wednesday Wellness, a free live educational series brought to you by Trinity Health. We're thrilled to have you with us as we dive into the important topic of innovative treatments for bowel and bladder incontinence. Before we get started, here are a few housekeeping notes. Your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during the presentation, please use the Q&A chat feature located at the bottom of your screen, and our presenter will address these questions at the end of the session. Lastly, today's webinar is being recorded and a link to the video will be sent to your email in the coming days. Without further ado, it is my pleasure to introduce urogynecologist Dr. Gianna Thompson.
Good afternoon, everyone. Glad you could join us. Today's topic is about how you can regain your pelvic health. So what options are out there for those of you who may have problems with the bladder or the bowel. So we're going to get into that in a second, but just to introduce myself, I am a urogynecologist. I've been practicing in the West Michigan area for 14 years after fellowship. And I really made it my passion in life to help women in particular try to live their best life. And one way to do that is to really improve health. And, my particular focus being then the pelvic health. And I hope to share with you some commonalities that patients that I see have in terms of what they tell me and what options may be available for you. So I'll start out by first just going over some myths. So kind of true, false statements. Is this true? Is this false? I hope to answer these in my presentation. So everyone should do a Kegel or tighten those vaginal muscles to maintain continence or make sure they don't leak and improve sex. Do you think that's true or false? Leaking. It's a normal part of aging. My grandma, my aunt had it, so I'm going to have it too, and everyone is just going to have to need adult diapers at some point. I'm the only one with pelvic problems. It definitely feels like that. Drinking water always makes me have to pee more, so I just try to abstain from drinking water. Surgery is my only option if I have problems with leakage. The best way to practice my Kegel exercises is while I'm trying to urinate. And then lastly, I'm not constipated. I have bowel movements every day. So we'll think about those as we go into this presentation today, and hopefully I can try to answer whether those are true or false. So I'm going to start off with broadly kind of what is the pelvis, and then we're going to talk about some specific conditions, and then I'm going to kind of put it all together at the end as to how those conditions may relate in terms of treatment options. So the pelvic floor, I want to call this the unknown gem. I think it's an area that we really don't get a lot of education about, whether that's in medicine or outside of medicine. But the pelvic floor is really important in how our bowels and bladder work. It's really important for sexual function. And the pelvic floor is made up of abdominal and back muscles that help to stabilize and support our spine. So the pelvic floor really extends even above what we consider the pelvis. And I would consider this to be an underestimated and overlooked key component to our health. So pelvic floor disorders occur in 1 in 3 women. So these women in this picture, 1 out of 3 of these probably has a pelvic floor disorder. That is the statistic that is out there, and that is a broad range of things. But you can see that these women are relatively young in the picture, and that may surprise you. It doesn't surprise me. I will see women from ages 20s all the way up into their 90s, and women can have problems with their pelvic floor at any point along the way. So what is the pelvic floor? Well, it is a set of muscles and ligaments. And in this picture, you can see here, this is the pubic bone in the front, and this is our spine and tailbone in the back. And this red line is representing the pelvic floor. The pelvic floor is a supportive structure to the vagina, the bladder, and the rectum, and the uterus. And it's a muscle and ligament. But this muscle is just like any other muscle in the body, muscles in your legs, and that muscle can be too weak or too tight. Most women are told that this muscle is weak and therefore they should always do Kegels. But oftentimes those muscles are too tight. Just like if you woke up with a sore neck because you slept wrong and you get a tension headache, same kind of idea can happen in the pelvis. And so not all dysfunction is due to just weakness of the pelvic floor. You don't leak necessarily always because it's weak. Sometimes you can leak because things are tight. And it really requires an experienced physician like myself or a pelvic floor physical therapist to really assess what that muscle is doing. Is the muscle tight or weak? So let's first talk about what's normal before we get to is abnormal. So urine and bowel incontinence are not a normal process of aging. Doesn't mean that, okay, as I get older, I'm just going to have to expect that. That's not the case. But do these statements sound familiar to you? Do you feel like you're going more than 8 times a day? Is your bladder always on your mind? Do you feel like you don't empty? And maybe because you're having to go right back to the bathroom and you get out a little bit more urine. Are you having to plan your activities around the bathroom? Do you need to monitor how much you drink and when? And are you wearing pads or diapers just in case? If this sounds like you, it's because it's pretty common issue that's going on. These are statements that I've heard from my patients when I arrive home. Even if I just urinated before leaving work, I can't make it in the door to the bathroom. I avoid drinking if I have to leave the house or plan what I'm going to drink or eat based on what my activities are in the day. I wanted to attend a family celebration, but I was afraid to travel because of my bladder. And my boss is always frustrated on how often I have to go to the bathroom. It's affecting work. I'm afraid to leave house, so I don't go anywhere. And on my trips down to Florida every year, I know where every rest stop is. I know where every bathroom is in the greater West Michigan area. 44% of people say they're embarrassed to talk about their bladder problems. And I hope that in bringing this to light, that changes it, that you're more willing to talk to friends or family members about it, because likely, just like you, they're experiencing some issues too, and you can help one another get to the right resources. So how does the bladder work? Well, normally our kidneys produce urine, and that urine is sent down these little tubes to what's called the bladder. And the bladder is just a holding vessel. It's a storage vessel. And when the bladder begins to fill, as it starts to get about halfway fill, there are messages that are sent via nerves up to the brain, making the brain aware, hey, bladder's kind of full. Maybe you should. Then brain send a message back saying, hey, you should think about finishing up your activities, finding the bathroom. So this bladder brain communication is essential for bladder control. And when communication breaks down, that's oftentimes what can cause bladder control problems. And so, versely, how does the bowel work? Well, with the digestive system pushing these boluses of stool through the colon and down the intestine into the rectum. When the rectum gets somewhat full, that sends a message via nerves. The bowel distends, and that nerve sends a message back to the brain that says, okay, that now you need to find a place to go to the bathroom. And then when a person is in the bathroom, those nerve signals allow that anal sphincter to relax and push the stool through. So again, this communication is essential. And when it goes awry, that's when we can see problems. So we'll come back to that. But it's important to see that both bowel and bladder have sort of a similar functioning mechanism. So let's talk about our bowels. Constipation and diarrhea, right? Those are two ends of the spectrum. And timing, it's not always that a patient or a person has normal bowel movements just if they're going every day. It really is also the consistency of the stool. So what we're looking for in consistency is what I call a soft form log, right? Not pencil thin, not balls of stool, but a soft form log. And that you're having those bowel movements every day to every other day. You might say, well, that's never been me. That's just not normal. I normally, go differently. But the goal is really to get you to that normal way. And so there's a lot of things we can do. I want to highlight Miralax, which is over the counter. It's the most common one that I think is effective. And the reason is because you can adjust how much you take to your body. So it's easier to titrate it or adjust it. And it's safe to take long term. It's just bringing water into your stool. We even start little kids on it. So it's really okay to take. Diarrhea, so if you tend towards the other way, then what do we need to do to get the stool to bulk more, to give it more form? Well, fiber is a big one. Citrusol, benefiber tend to be more tolerated, but also potentially having a workup done by a gastroenterologist to make sure there isn't some other reason that you're having diarrhea. And this is important because the bowel and bladder really are kind of best friends. They both live in that pelvis, supported by the pelvic floor. The nerves that support the bowel and the bladder are nearby. And so when the bowel's unhappy, the bladder is, and vice versa. So in my profession, I really can't talk about one without the other, because the treatments that I give and the therapies that are available really are essential that both the bowel and bladder are working well. So what can go wrong in terms of bowel control? Well, bowel control problems or fecal incontinence is where someone loses the control of their bowels. This is typically a chronic reoccurring condition. It's not like, oh, I had food poisoning and then, I had an issue. This is something that's ongoing. And this can either be that they get the urge to have a bowel movement and they just can't make it to the bathroom, or they have what we call passive incontinence. This might be that they weren't even aware that it happened. Maybe they coughed and some came out, or maybe they go back to the bathroom and they realize there's a smear on the pad or the underwear and they thought that they wiped clean. Oftentimes people will blame it on hemorrhoids, but I would say hemorrhoids is not typically the issue. And so one of my patients said, I've stopped seeing my friends or going places because I'm just afraid I'd smell like poop. And so this is a common problem that I see that I hope to help people with. So we'll come back to the bowel, but now we're going to switch gears again back to the bladder, and we're going to talk about two different problems that are considered leakage or incontinence. And I need to differentiate these for you because they're very different in terms of why they happen and what we do to treat them. So this picture may look like there's a lot of confusing things, but I'm just trying to differentiate what urge leakage is from stress leakage. Stress leakage is what we are probably very familiar with. I leak when I cough, laugh, sneeze, jump up and down. And that's due to loss of resistance at the outlet. The outlet is what's called the urethra. This is the bladder. This is the urethra. And when those muscles or the supportive structure of the pelvic floor is either too tight or too weak, we can lose control here. And what happens is when there's a big abdominal pressure, we cough, we sneeze, we lift something, that loss of resistance at the urethra allows us to leak in those instances. But this is very different than someone who leaks with little to no warning. Maybe they get the urge and there's just no time to make it, or all of a sudden they stand up from a chair and urine's coming out. That isn't from pressure from the outside of the bladder. That really has to do with increased pressure inside the bladder, which is what these red arrows are representing. This is representing irritability or spasming or contraction of the muscle of the bladder. And this muscle inside the bladder is very different than that pelvic muscle that I was talking about that supports. That's kind of holding, but this muscle is the muscle inside the bladder. And that, when the muscles and nerves of the inside of the bladder go awry, that's when you can get more of that urge leakage. And I just made this point here, what's mixed incontinence? That's if somebody has both. And that's very common. You might have leakage when you cough, sneeze. You might have leakage with little to no warning. And so it's teasing out, which one do we address first and how do we address that? So again, what are the causes of leakage when you cough, laugh, sneeze? Well, childbirth is probably the most common, but aging, loss of estrogen, there can be a genetic component. You could have had pelvic surgery like an ablation, a hysterectomy that may have led to that. An overactive bladder. So to describe this more, I did describe sort of that leakage with little to no warning, but this is the person that's thinking about the bathroom, feels like they emptied the bladder, but that urge comes right back. So that's more the frequency urgency thing. They're going more than 8 times a day, and they just feel like, oh, I'm constantly in the bathroom. Some of that group that has overactive bladder leak. More times than not, most patients with overactive bladder just have to go frequently and have urgency. But about 30% of the group of overactive bladder also leak before they reach the bathroom. And some people tell me, well, I don't leak. I flood. I'm peeing myself. Well, that is a form of leakage. You didn't give permission for the urine to come out. And so whether it's drops or whether it's a bladder full, it is incontinence, which is involuntary loss of urine. So it would encompass any patient with either small or large amounts of leakage with little to no warning. And what might cause urge leakage or overactive bladder versus what I talked about with the stress leakage? Well, most of the time we don't know what causes overactive bladder. That's what idiopathic means. We don't have a cause. Pelvic floor, those muscles, right, that we were talking about, too tight, too weak, that can contribute to it. Orthopedic problems, you might be surprised to hear that, but people who have had knee replacements, hip replacements, low back pain. Again, I told you the pelvic floor starts higher than the pelvis. So the muscles that stabilize our spine, our hips, all of those are involved in how the alignment of the pelvis is and what's happening to that pelvic muscle. That pelvic floor muscle attaches to the inside of our hips. So if we have dysfunction in the hip, guess what? That muscle of the pelvic floor isn't working the way it should. Pelvic surgery, hysterectomy, ablation, colon surgery. Anytime we're working around those nerves of the pelvis, that can affect the bladder. Infection, urinary tract infection, a tumor, a mass, a stone in the bladder, possible, not very common causes. Structural problems, not very common. And then neurologic problems, spinal cord injury, stroke, multiple sclerosis, those could be other causes. So what is the treatment? Well, as I told you back in that picture, right, we're trying to differentiate because they're different problems. One's caused by problems with the outlet and the other's caused by problems with the muscle of the bladder. Therefore, the treatments are going to be very different. So this is just a slide to, again, reiterate this point that I really hope that we as a community and culture can really do a better job of talking to one another about these problems and really letting our friends and family know, hey, you have this too. I know where I can help you. And this is just to say that the data really shows us that about 1 in 6 adults have overactive bladder, which is extremely common. And these problems shouldn't be ignored. They can lead to loss of sleep, right? I'm getting up a lot at night, loss of confidence because I don't know when it's going to happen. And just overall poor feelings of health. And this affects, if we take this 1 in 6, that's 37 million adults in the US, which may surprise you because that makes it more common than diabetes at 30 million. It makes it more common than people with vision problems at 12 million. And yet these are things we hear about all the time, right? Maybe they're not embarrassing to talk about. So they're talked about on our news media, et cetera. But this is really more prevalent. So we're going to go through overactive bladder treatments, and then we'll go through the leakage with coughing, sneezing, or stress incontinence treatments. So to start with overactive bladder, frequency, urgency, leakage on the way to the bathroom, I think about the treatments as sort of layered. So they're additive. It might not be that one treatment by itself works, but it's maybe putting different pieces of the puzzle together. First thing is we need to diagnose. And then the next thing is to look at, well, what things in your lifestyle could be contributing to this? These can be simple solutions that help people, but may not work for everyone. And again, it could be part of the issue, but not completely curative. So let's look at our diet. Well, if you're drinking a lot of coffee, a lot of soda, a lot of things with what I call fake sugars like sucralose, fructose, those things are irritating to the lining, that inner lining of the bladder. It's like just acid to the bladder. And so if you're drinking what I'd say more than 2 cups of those things, I would really try to limit that and increase your water just to decrease what's irritating the bladder. Bladder retraining, this can be working on sort of urge suppression. When you get that urge, stop, deep breathing, trying to lessen that urgency so then you can make it to the bathroom. And that's techniques that pelvic floor physical therapy can work with you on, as well as working on that pelvic floor. So if someone was to have a tight pelvic floor, that muscle squeezing around the bladder and the urethra outlet, and that can actually cause someone to leak, not just because it's weak. And so pelvic floor physical therapy can be extremely helpful in getting that muscle to relax. If we can get that pelvic floor muscle to relax, we can get the bladder to function better. And so that is done by a series of techniques where the physical therapists do massage. These are women physical therapists that are specially trained in it. But I'll tell you, it can be successful in about 70% of patients. And then bowel management, right? Because I told you the bowel and bladder are kind of hand in hand. So constipation, diarrhea, managing that as well. What do we have beyond that? Well, medications come into play. These medications work on the bladder itself to get the bladder to hold more, give you more warning time, help give you better control. But medications have side effects. Unfortunately, some of the side effects of these medications are things we're trying to avoid, like constipation and dry mouth. There is a class of medicine that doesn't have that, but unfortunately, this is kind of one of the things we got to work around. I do have patients that have significant improvement on medication, and they take those for many years. And I have patients that, it doesn't work, and they've tried it. So what else is there? Well, what else is there is what we call advanced therapies. And it's really important to understand the differences here, because some of these therapies I'm going to talk about will help with the bowel, but also the bladder. So it can help patients with leakage of stool and leakage of urine. Some treatments only help with the leakage of urine. So we're going to go through these. So Botox. Botox is an option. This can be injected into the bladder wall. So here you're seeing a camera called a cystoscope inside the bladder, and then these little circles indicate where the Botox can be injected. Now, I'll tell you, I don't inject in that many places. I'd say in general, it's about 10 injections. It's done with a tiny needle, and it's well tolerated. And this is done in the office, and it's repeated about every 3 to 6 months because Botox wears off and the symptoms can come back. The goal of any of these treatments or advanced treatments is to improve the symptoms by 50%. You might say, well, wait a second, 50%, I don't ever want to leak. The problem is that we're dealing with function of a muscle, not necessarily support that we'll get to, but with overactive bladder, we're dealing with function. And so again, it's trying to reduce acids in the diet, working on the bowels, bringing in another therapy. But oftentimes we can't get that bladder to function like it did at 18. The goal is to try and get you to function better. So if you're wearing, let's say 5 pads a day, maybe we can get you down to 2, or the amount you're leaking would be reduced by half. And so of the patients that do Botox, about 60% of them receive 50% or more improvement. One thing to point out is that Botox, because it's trying to slow or stop function, in some people it can slow it down too much. And there's a small risk that you may have to use a catheter to help empty the bladder in some cases. Now we're going to move to this idea again when we were talking about the communication between the brain and the bladder via the nerves, and how breakdown of that communication can be a problem. These 2 treatments address that communication. So instead of medications and Botox that work on the actual muscle of the bladder, these are trying to work on the communication. So tibial nerve stimulation is exactly what you're seeing here. This nerve that sits near our ankle runs up the leg and meets up with your bladder nerve in the spinal cord. So when we stimulate this tibial nerve, and done here in the office with this tiny needle, we can change the behavior of the bladder. So these are 30-minute treatments in the office. You come in, this tiny needle is placed. It's connected to this little device that provides stimulation, which is comfortable. And the goal is to reduce your urgency, your frequency, your leakage with little to no warning. After those 12 sessions, the treatments would then become monthly to maintain the benefit, assuming that you're getting that 50% benefit. And then we're now going to move to another form of what we call neuromodulation, or restoring that brain bladder communication. This is sacral neuromodulation, different than tibial nerve modulation. This is where now we're going to talk to the nerves of the bladder closer to the action. So instead of way out by that ankle, now we're going to talk to the nerves closer to the bladder. And this involves gentle, comfortable stimulation to that nerve. It involves an office test where you'd come in, I would place the wires under the skin and allow you to try it for a week. At that end of that week period of time, the wire is removed. So if you didn't like it, it's completely reversed. But based on that trial, the next step would be outpatient surgery, where you'd get a little sedation like a colonoscopy. And then I would place this little wire down in the natural opening in the tailbone, and it would connect to a little battery that would sit up in the upper butt cheek. That's what this picture is showing. So the little wire sits here, and then it connects to this little battery. Battery life is 10 years. This has been around since 1995. And I say that because it surprises me in 2024 that there's still people that haven't heard of this therapy. It's very well studied, well researched. And the amazing part is that it also helps with bowel incontinence. So this is the one treatment that helps with both bladder and bowel leakage. So tibial nerve stimulation only helps the bladder. Botox only helps the bladder. But this one can also stimulate the nerves to the bowel and the bladder. And it's the same procedure. It's the same wire. And what's amazing is that patients who experience leakage of stool, whether that's a smear, whether that's a formed stool, whether it's a larger accident, they see 50% reduction in those episodes. 90% of those patients, or 89%, see 50% or more reduction. And this is looking at a group over a 5-year period of time. They sustained benefit. 82% of patients in this group studied over 5 years achieved 50% or more improvement in their bladder symptoms. And there was a 3 times greater improvement in quality of life measurements. So what does that mean? Well, when you're doing a study and you're comparing 2 groups of people, there's basically a break point where it says, okay, if patients meet this sort of line of improvements in quality of life, then that's a significant improvement. And patients noted a 3 times greater improvement than sort of that basic line where you'd need to see a difference. And that was compared to medication. So the improvements are quite significant in the group of patients. And again, I think the reason is that it's trying to restore normal. So what do my patients say who've had this? Well, they've said, I had a patient came in the other day, said, you gave me my life back. I'm not pooping my pants. I didn't know if it would work for me, but I'm so glad I tried it. This was from a patient who saw me year after year, was bothered by her bladder symptoms. And we'd gone through the medications and things. And I said, okay, let's give this a try. And she just wasn't quite ready to do it. Just seemed like too much. Eventually, she gave me the opportunity and she was just pleased. Another patient said, I was able to attend my grandson's wedding, and I'm really thankful because prior to that, I would have been too nervous to travel, been too nervous to go to the wedding and not know where the bathroom was. And again, another patient wishing they'd tried it earlier. So that's overactive bladder. Again, that irritability of the muscle of the bladder itself. Now we're switching gears to what we call stress incontinence, leakage with coughing, sneezing, jump up and down. That's change in support under the bladder. And again, muscles can be too tight, muscles can be weak. Physical therapy is a great option for this. Kegels, tightening that muscle, right? Might be a good option, might not. And it all depends on how much tension is in that muscle, how much tightness is in that muscle. If the muscle's tight and you try to squeeze it, it's not going to do much, right? We need to get that muscle to relax, and then you can get a good contraction to really help prevent that leakage. Medications do not work with this. So things like oxybutynin, sulfenacin, myrbetriq, Vesicare ditropan, Detrol, they don't work for this. Those would be medications that help with overactive bladder. There are vaginal inserts over the counter, things called Impressa or Revive that you can purchase. They go in like a tampon and they provide support under the bladder to help prevent leakage. I think this is a reasonable option if the leakage is occurring periodically or episodically, like maybe it always happens when I run. But I'm not sure it's the best option if you're having to wear it all day, every day. If you're needing to wear it all day, every day, and you would prefer this option, we have what's called a pessary, which is a silicone disc, usually used for another condition called prolapse, which I'm not talking about today, but we do have pessaries that help with leakage. And those are ones that you can wear all day, every day, and maybe clean once a week versus having to take it out and exchange it every 8 hours, like the products on the market or over the counter. So surgery would be another option for leakage with coughing and sneezing. And this might be something you're more familiar with. You've probably heard of someone, a friend or family member or yourself that's had a sling. So what is a sling? A sling is a piece of mesh shown here that sits under the urethra. But there are other ways to do slings. You can have a sling that's made of your own tissue. We can take fascia off your muscle, your abdominal muscle, and use that. Or you can have what's called a bulking agent, which is represented by this little gel droplet. So I'm going to go into these more in depth. So this is just a picture to say that slings have great results. And the sling is pictured here in the bottom right. This is the bladder and then the urethra tube. And remember, we talked about the support changing under the urethra and creating loss of resistance. And so a sling is a piece of mesh that kind of sits under that urethra tube, not the bladder. It actually supports the outlet. So when you cough, sneeze, jump up and down, there's good support. And that's shown here, kind of sitting, if this is the vaginal opening, here, this little opening here is the urethra. That sling lays under the vaginal wall, right under the urethra, and supports kind of like a little hammock. And 90% of people are dry after this procedure. Bulkamid. So if you decided, nope, I don't want to do a sling, and I would say for most people, we do mesh slings because the results are great. They've been on the market for 30 years. There are times where people need to have a tissue sling, but the tissue slings are more invasive. You have another incision to heal from. There's a higher chance of not being able to pee or having more irritable bladder symptoms. So the vast majority of patients receive a mesh sling. And obviously, if that was something that sounded of interest to you, we could discuss more in depth on that. But the other option for a procedure is what's called a bulking injection. So instead of sitting outside the urethra like a sling, this is going inside the urethra. So these little white ovals represent the bulking agent that was injected through a tiny scope. This currently is done under some sedation in the operating room, and that little gel product is injected here. 97% of it is water soluble, and so what's left behind is this gel that your tissue grows into, and it pushes the edges of that tube closer together, kind of like collagen into the lips. It creates more resistance to urine coming out, and this is 80% successful. And why it's a game changer is that this product is newer to the market. We've had bulking agents for years and years, and we've tried different things, and they've been difficult to inject or haven't had great results. But this seems to be easy to inject. It seems to give great results. Patients are back to all their normal activities within 24 hours, where with the sling, it's about a 2-week period of time where you're not doing heavy lifting, running, things like that. So some patients kind of like getting back to their activities quicker. But the other important thing about this is that this product does not seem to create inflammation, which was true of some of our other products. Inflammation can lead to scar tissue. Scar tissue in this tiny urethra can be a problem. So this is really an innovation and improvement. This product's been in Europe for 7 years, so there's great long-term data on it. In Europe, it's only been in our U.S. markets for maybe about 3 years. So we're going to conclude now with going through our myths. So hopefully you have your questions ready in the Q&A. But these are hopefully the things we've answered today in this when I've gone through this talk. So everyone should do Kegels to maintain continence and improve sex. Well, hopefully you know that's false, because Kegels are helpful if the muscle's weak, but not all pelvic floor muscles are weak. Leaking is normal part of aging? Absolutely not. I treat many women that are of all age groups. Is it more common as we get older? Yes, but it's not a normal part of aging. I'm the only one with pelvic problems. Well, if you remember that statistic in the beginning, about 1 in 3 women have a pelvic floor disorder. So it's quite common. Drinking water will make me have to pee more. Well, drinking fluid, if you have overactive bladder, will make you feel like you need to urinate more, but you also need water to make sure all the body processes work well. About 60 to 80 ounces a day is typical, but we want to minimize putting other things in the system that are acidic, the coffee, the soda, the Propel waters, things that have those fake sugars, because those are more irritating than the water. Surgery is my only option for incontinence. Well, hopefully you know after that talk today that that's not true. We have a lot of things that are non-surgical. The best way to practice Kegels is while urinating. This one I didn't address specifically, but no, this would not be a great time. And if we remember back to that slide between the brain bladder communication, if you're sitting on the toilet trying to urinate, your brain has sent a message to the bladder that says it's okay to empty now. And now if you try to tighten that muscle, it confuses the brain. So you could try to find the right muscle when you're urinating, but I wouldn't in general practice that while urinating, because it can confuse your messaging system. And then lastly, I'm not constipated. I have a bowel movement every day. And again, even though you have a daily bowel movement, it's also important what the consistency is. So if you're having normal, soft form stools and they're daily, then yes, I would say you're not constipated. So with that, hopefully we can open that up for questions.
Yes, thank you, Dr. Thompson. We'll now transition into our Q&A session. If you haven't already, you may submit your questions using the Q&A chat feature at the bottom of your screen. And to kick it off, we have a question that is asking, how do you determine if muscle is too weak or too tight?
Great question. So this is done on a pelvic exam. So just like with any other muscle, if you were to see a chiropractic or massage therapist, right, I can actually feel in this pelvic muscle if there's knots or tension, spasm. Sometimes the muscle will feel like it's a guitar string, like it's taut. Sometimes you'll actually feel a knot within the muscle. And typically, if I just place my finger on that pelvic muscle, and again, that muscle lives right behind the wall of the vagina. So if I place my finger there and I touch that and that's tender, that's another indication that the muscle is under tension or spastic, because a muscle should not be tender. And then if you had tenderness or spasm, a referral to a physical therapist to get that muscle out of spasm so the right and left sides of your pelvic floor can work together would be ideal.
Great, thank you. The next question is asking, does prolapse cause these same symptoms and are the treatments similar?
So prolapse, which we didn't get into depth about today, is a condition where the vaginal wall is falling or coming down. And so women would experience a bulge or a protrusion. Yes, women with prolapse can have incontinence or frequency, but they aren't necessarily, it's not necessarily the prolapse that can be causing the incontinence. It's not necessarily a one-to-one. Women can have prolapse, they can have incontinence, they can have both. And the treatments for prolapse are different than the treatments that we talked about today. So the treatments for prolapse, or that bulge that's coming out, would be to put the bulge back in, right? And you can do that by wearing a device called a pessary, which goes in and holds the wall up, or having surgery to the vagina to repair that bulge and make it go away. But often what I tell my patients who have that condition, but are also bothered by going frequently or having leakage, is that fixing their prolapse won't necessarily make their bladder symptoms go away. And so we're usually doing more than one thing based on what the leakage is.
Thank you. Our next question, and we have a few that are asking, it looks like the similar thing, which is, do they need a referral from a primary care provider to see a urogynecologist, or is there a way to schedule an appointment directly?
Yes, we typically need a referral from either primary care or gynecologist. And my office staff can walk you through that, how to get that. Sometimes I'll get referrals. Patients have sent a my chart message to their primary care, or they've had a telephone message, or a true in-person visit where they've said, hey, I'm having this problem, and then based on that problem they can get referred. But the reason that we require referral is to, a lot of times insurance requires it, but the also is that the primary care can often tease out if it's appropriate to send, or if there's other things that need to be worked up or looked at first. Maybe, make sure you don't have an infection or something like that. But yes, you can call the office and they can walk you through how to get that done if you'd like.
Thank you. Our next question is asking, I had a total hysterectomy about 8 weeks ago. Occasionally, when I start running or walking fast, I will have some urine leakage. Would physical therapy be a good choice? Anything else I should do in conjunction with therapy?
Yes, physical therapy would be a great option at 8 weeks. Most of your activity restrictions are usually lifted at that point. And so that soon after surgery, I still think there's a good chance that you may see improvements just with continued healing. So even though your overactivity restrictions, healing's still going on inside the body for about 3 months. But yes, physical therapy would be a great option. You just want to make sure that it was a pelvic floor physical therapist who's really comprehensive. So you want somebody who isn't just going to do Kegels. They really can do Kegels or what we call manual therapy, depending on what you need based on how that muscle feels. And your primary care can always reach out to my office. I have a list of physical therapists that do this in the greater Michigan area. There's many in the Grand Rapids area, as well as Muskegon, and kind of all over West Michigan.
Thank you. Our next question is asking if you have any best practices for performing Kegel exercises.
Well, when I talk a patient through how to find that muscle, it's more of a pulling up and in. And so a lot of times what patients are doing is they're kind of squeezing their butt together, but it's sort of those really inner muscles. And so it's not a bad idea to find that muscle while you're trying to urinate. It's just you don't want to practice it while you're urinating. The other way to describe it is if you're trying to hold back a fart. But basically, it's a pulling up and in from your low pelvis in through your core, and just kind of getting that pulling sensation. You could also try placing your own finger there and seeing if you can squeeze that muscle around it. But those would be the best ways. I would not recommend doing more than 30 per day, maybe 3 sets of 10 would be the most that I would have somebody do that. And if you're having any pain in the pelvis, I definitely would not do Kegels, because again, those muscles, or pain in the pelvis, there's many reasons for pain, but it can indicate that those muscles are tight.
All right. Our next question is asking, how can I keep from having to urinate in the middle of the night?
Yeah. Well, nighttime, we didn't kind of delve into this, but nighttime frequency, getting up and going frequently at night, can be related to overactive bladder, which we talked about. It's where you feel like you have to go frequently. You go and there's small amounts. And some people experience those symptoms more at night than during the day. And so if it's that you're going frequently at night, there's small amounts, it feels urgent, a lot of those same overactive bladder treatments that we talked about. What are you eating and drinking, particularly before you go to bed? If you're having alcohol, you might want to minimize that, making sure you're not constipated, physical therapy, medications, advanced therapies, all those would be available. On the other hand, if you're somebody who's going frequently at night and it's seems to be large volumes of urine, there are other causes for nighttime frequency. And one of those is sometimes we can make too much urine. So the urine production, we make too much urine at night. And that can be sorted out on a diary where you'd record everything, every time you went to the bathroom during the day, every time you went at the night, and how much was there. And if somebody's making at least 30% of their total urine in their nighttime hours, that can indicate another issue with production. And those treatments are different. So if you're someone who seems to be making a lot of urine at night, you may need to talk with your primary care physician about that, making sure there's not diabetes or sleep apnea or other things contributing to it. But that is a different issue.
Thank you. I hope I pronounced this next question correctly, but it is asking, should a cystoscopy be done initially to determine there aren't any issues such as a tumor?
Good question. Yes, cystoscopy is an option, but no, typically that is not required in the workup of someone who has frequency, urgency, leakage. And that's true in the guidelines. So if you look at the American Urologic Association guidelines of how to work up bladder conditions, cystoscopy is not required. It is a tool that is available. Tumors, stones are very uncommon cause of these conditions. The more common cause is we don't know why they develop. Having said that, if you're somebody who had those symptoms and blood in the urine, either blood that you see, or if you had a urinalysis done and there was more than 2 red blood cells, then that would be an indication to look in the bladder. But without recurrent infections and bladder symptoms or blood in the urine and urine symptoms, looking in the bladder would not be at the top of the list. Now, if you tried some things and those treatments weren't working, then that might be a reasonable time to look in the bladder.
All right, thank you. Our next question is asking, when I pass gas, which is frequent, I have fecal smear. Do you know what might be causing this?
Well, again, the bowel incontinence happens for a number of reasons. There's not only muscles, so the sphincter muscles, but there's also muscles within the bowel itself. There's nerves that are in play there. And so we can't always know what the breakdown is, right? There are patients that have had surgeries to their bowels, right? Maybe they have a history of Crohn's or ulcerative colitis, some more inflammatory conditions that could contribute. But oftentimes we don't know. I think the biggest things would be, what are your bowel movements look like, right? If you tend towards diarrhea, using fiber to bulk it. If you tend towards constipation, using something to get the stools more soft and form. And then if you're having normal, soft form stools, irregular, and the smearing still happening, then it might be looking into one of these other options like sacral neuromodulation. Have you had a recent colonoscopy? That would be the main thing. There's testing that's out there, things like anal manometry, which there's a bunch of fancy tests, but none of them have shown that in doing that testing, it tells you any more likely what the problem is or any more likely what the treatment should be. So once you've worked through, are there any triggers in the diet? Dairy being a big one that can cause bowel incontinence, so yogurt, cheese, milk, trying to reduce that. So could there possibly be triggers in the diet? What are the consistencies of the stools? Do you have an up-to-date colonoscopy? Then the next step, really based on the guidelines with the Colorectal Society and the Gastroenterology Society, would be to do a sacral neuromodulation trial and see if improving that communication between the brain and the bowel would make a difference in those episodes.
All right, thank you. Our next question is a little bit of a two-part. The first question being asked is, if they are wearing mini pads that are damp in the morning, can they be leaking throughout the night without realizing? And the second part to their question is that when they are swimming, they get a constant feeling of having to urinate, and does being submerged have a wicking effect to the bladder?
So the first question, if the pad is damp in the morning, could it be urine? Yes. Could it be sweat? Could it be discharge? All those things are possible. It is possible to leak urine without being aware, and that may or may not be related to overactive bladder. If you don't have any daytime frequency, daytime urgency, you're not leaking during the day, then it may be an isolated occurrence. Again, things to be mindful of there. What are you eating and drinking, especially before bed? If you may want to consider decreasing fluids after supper time or cutting them out altogether. Again, making sure the bowels are normal, but then potentially looking at other treatments, particularly if you have daytime symptoms as well. So yes, that's possible. There's a medication that I can give if somebody's like, I'm not sure if it's urine or something else. There's a medication that we have called Peridium that turns the urine orange. And then if you have orange show up in the pad, well, then you know it's urine versus a vaginal discharge. The second question that you gave was about, you might have to read it to me again.
Yes. The second question was about being submerged in water
Oh,
and
yes,
if that.
swimming. Yes. So
Mhm.
the swimming, there's no data that says submerging into water puts more pressure on the bladder and makes that more likely. But often patients that are in the pool swimming will notice it more. They notice it more when they're in cold environments, that their bladder is more irritable. So it may be more related to temperature of the pool or the activity than so much the submersion of it. But often common triggers are cold weather, which pools can be cold, putting their hands in water under a faucet, or even stress, anxiousness. All those things can be triggers. So it could just be that you're in cooler water or in water in general, and then that just sort of triggers the bladder.
All right, thank you. Our next question is asking, are IBS and bladder urgency related or two separate issues?
Well, IBS is irritable bowel syndrome, and irritable bowel syndrome and urinary bladder urgency can go hand in hand. But you can also have them separately. But what I would say is somebody who's dealing with irritable bowel often has spasticity, irritability. And so, again, that can be with the muscles and nerves of the bowel, and those can trigger the bladder. So it would be fairly common to have an overlap of those symptoms. And again, treatments would be, as we talked about, before, trying to have good, healthy bladder habits, good, healthy bowel habits in terms of what you're eating and drinking, potentially pelvic floor physical therapy, improving stool consistency, would all be things that you could do to help with that interplay.
All right, our next question is asking, it sounds like I may have an overactive bladder, but I'm going to have hip replacement in 2 weeks. How long should I wait before contacting a urogynecologist?
Mm-hmm. I would say 3 months probably after hip replacement, just because you're going to be undergoing a period of time where you may not be able to put full weight on it. Then there's going to be a rehab period where you're getting those muscles of the hip to fire again. And so you may find that some of those symptoms improve or stabilize. So I'd say, 3 months, or at least until you're not having any activity restrictions, right? You're fully weight bearing, you're through physical therapy. Maybe that's at 8 weeks. But I would say that would be a good time frame.
All right, thank you. Our next question is asking, towards the end of the day, I will get a burning sensation towards the end of peeing. It doesn't seem like PT or seeing a urologist or meds are working. Is there any insight you might be able to provide as to why that burning sensation may have started up?
Well, burning in the vagina with urination can be due to a few things. One, did you see a physical therapist that did manual therapy, or did they just have you do Kegels? So sometimes the burning sensation can be because those muscles are too tight around the urethra and they're not relaxing. So you need what's called a manual physical therapist, somebody that will massage that muscle internally. So that's number one. Number two, making sure you're not constipated. That can be a cause of burning of the urethra. Number three, avoiding irritants, things in the diet that could be contributing to that. And then number four, if you're of perimenopause or menopause age, estrogen cream can be very helpful for sources of burning. So sometimes burning can be due to dryness of that vaginal tissue that sits outside the urethra. And when estrogen cream is applied, it brings back your natural lubrication, and that can help with burning. Beyond that, it would be, looking in the bladder, making sure there's not something structural, etc.
All right, thank you. Our next question is asking, having to use a pad because of bowel leakage. What can be done to stop this? I have loose bowels at times and sometimes don't make it to the bathroom.
Yeah. Well, I think again, if you've worked on things that are diet triggers in the diet, if you're having diarrhea using a bulking medication, or if you're having constipation using something to help with that, the next step would be to think about something like sacral neuromodulation, which again is that small wire that's placed down low near the tailbone, sits near the nerves to the bladder and the bowel. And during a test period, which lasts about a week, that wire is taped to you after being placed in the office, and you would then see if you had at least 50% improvement in those bowel accidents. And then if you did, could consider going on to something more permanent. That would be a consideration.
All right. Our next question is asking, I use an electrolyte powder and water once a day. Could that be contributing to bladder irritation?
Possibly, depending on what else is in the electrolyte powder. So if there's things like sucralose, aspartame, etherinol, which is another sort of sugar substitute, fructose, those can be so a lot of those things that, like in Crystal Light, make it have the sweeter flavor. If you have a sweeter flavored powder, something in there is the sugar substitute, and that can be irritating to the bladder. But if there isn't one, if it's just electrolytes, then I wouldn't expect that to necessarily be the cause. But most of those powders have some kind of sugar substitute in them.
All right, thank you. Our next question is asking, can the nerves, I think I'm saying this correctly, can the nerve stim treatments for bowel incontinence help if you have MS?
So what I would say to that is patients with MS can have bowel and bladder issues. And bowel and bladder issues can be treated with the nerve stimulation, whether or not you have MS. So yes, it would be something that you could try and see if it helps. You don't know until you have a trial of it.
Perfect. Well, that was our last question, and we are just at time, so that was perfect timing. Thank you once again, Dr. Thompson, for your presentation and insightful Q&A. To all our participants, thank you for joining us, and we hope you have a wonderful rest of your day.
Thank you. Take care.